Hello and welcome everyone to our webinar VEDS Emergencies, Know When to Go and What to Say. On behalf of the Marfan Foundation and the VEDS movement, we are thrilled to have you join us for this very important discussion. Today we are excited to be joined also by Dr. Shane Morris and Rob Penna. Dr. Morris is a pediatric cardiologist and associate professor at Baylor College of Medicine, specializing in cardiovascular imaging and genetics. She serves as the medical director of the cardiovascular genetics program at Texas Children's, and is also the medical director of the fetal cardiology program. Her research aims to improve outcomes for children with genetic aortic diseases, investigating novel imaging markers to predict long-term outcomes and optimize care. We're also joined by Dr. Penna. Dr. Penna is a senior emergency medicine resident physician who will begin his training in anesthesia critical care at the University of Michigan next year. His research focuses on Marfan syndrome and related connective tissue disorders, as well as the diagnosis and management of aortic disease in the emergency department and the ICU. He has Marfan syndrome himself and underwent bilateral lens replacement and an aortic root replacement as a young man. Today, our experts will guide us through recognizing critical emergency symptoms, making informed decisions about when to seek treatment, and communicating effectively with first responders and emergency department staff. Dr. Morris will focus on the pediatric population, while Dr. Penna will address adult concerns. We'll have some time for questions at the end, so please use the Q&A feature of Zoom to submit your questions. And if we are not able to address your question during the webinar, please don't hesitate to reach out to our Help and Resource Center, which can be found at marfan.org/ask or thevedsmovement.org/ask. This webinar will be recorded and available on our YouTube channel, but will also be a key resource on our emergency preparedness section of the VEDS Movement website as well within just a few days. So now let's empower ourselves with vital knowledge to navigate VEDS-related emergencies much more confidently. And at this point, I'll hand it over to you. Thank you, Dr. Morris.
Great. Nice to see everybody. Nice to be part of this. It's going to be kind of hopefully an easily flowing, casual conversation. And I really look forward to the questions about what your concerns are. I think I need permission to share, Ryan. There we go. All right. So we're going to talk about VEDS emergencies, know when to go and what to say. Specifically, my talk is going to focus on kids. And, I definitely have given emergency talks before, and I usually talk about all the things that can go wrong, but we're going to talk a little bit more about symptoms. When you're having this, should we go or should we not? So first, what could take a child to the ER? And there's a variety of things. It could be a lot of kids are on medicine, missing a medicine, maybe an accidental medication overdose, of course, an accident or injury, shortness of breath, all sorts of different kinds of pain, neurologic symptoms, and bleeding. I think these are probably the most common symptoms that I get called about, and then we see kids with VEDS in the ER. And the discussion, we're going to go through each of these of sort of when to worry and when do we not think we have to worry. Also, please, please, please put questions in Q&A. I'm happy as we go along to answer them. If Ryan wants to interrupt me at any time, or if I've left something off that kind of people worry about, please let me know. All right. So we'll talk about the easy stuff first. So medication. So, it's really easy to miss a dose or occasionally accidentally take too much. You've missed a dose, or you take a pill and you can't remember you took it, and then taking another pill. Now, we don't get calls about this too often, but sometimes we do. And when do we need to worry about that? Well, it really depends on the medicine. And I'm going to go through some of the more common meds that people are on. So for the most common cardiac meds that people are on, and these include beta blockers and angiotensin receptor blockers, missing a dose is not the end of the world. We don't want people to miss a dose, but it's not usually going to cause a major problem. And if you take a double dose, it's rarely going to cause a problem too if it's one. Now, I will say with beta blockers, especially if you're on labetalol or metoprolol, your body can get really used to having that nice low heart rate. And if you miss a dose, those are both longer acting, especially if you're on the longer acting one, for people's heart rates to go up when they miss a dose, and then they feel heart racing. And I get calls probably once a month saying my heart is racing on my beta blocker. And when we talk more, it's actually that they've missed their beta blocker and their heart rate is coming back to like a normal rate, but it feels funny. So that is something that feels funny, but it's not usually an emergency. Same with aspirin. Some people are on aspirin. for after after a vertebral artery dissection or a smaller vessel dissection. While we don't want to miss any of these, it's usually not an emergency. Now, I know we're focusing on kids, but we do have some kids that are on birth control for period regulation and also some adolescents. Of course, you don't have to go to the ER, but it is a big deal to miss a birth control pill. Again, you can do one time of taking a double dose, but you can't take more than that. It can really mess up your hormones. Spironolactone is sort of like beta blockers and angiotensin receptor blockers. It's not the end of the world if you miss a dose. If you double up a dose just once, it's probably okay, but you have to be careful taking it too long because it can affect your electrolytes. Now, the meds we really do have to worry about are ones that not that many people with VEDS are on, but some people are, and these are called the narrow therapeutic index meds. So these are seizure medications, thyroid medications, digoxin are some examples. These are ones where the effective index is very small. So if you go over high, you could actually have toxic effects. And if you go under, you're gonna really have, you really could not be treating your condition. So these are ones you have to be more careful about on sort of either end. And of course, insulin, but I think there's very few patients with VEDS on insulin. All right, we'll get into some of the other kind of more serious conditions. So accidents and injuries. So kids hurt themselves all the time, right? It is really common. My kids, I have 3 kids, they have gotten into all sorts of accidents and injury, and I've been to the ER numerous times. So when do we really have to worry above and beyond in VEDS? So first of all, anyway, for anyone with VEDS, I would definitely have a low threshold, right, to consider going. But do you have to go in every single time they have an accident or an injury? So I would say the times to go in are obviously if there's excessive bleeding, if you have a really large hematoma that is continuing to bleed, this is bleeding under the skin or is causing a lot of pain. If you have moderate to severe pain or atypical pain that won't go away, right? You have a bike accident, not every bike accident has to go to the ER, but if any of these are happening, there's a pain somewhere that's just not getting better, that's when I would get investigated to make sure there's not some internal bleeding somewhere. Any neurologic symptoms. So these are, weakness, numbness, visual complaints, swallowing complaints, anything that affects the neurologic system, I would get seen for. Also a racing heartbeat. So sometimes if there's blood loss, you may not experience pain, but it does make kind of like dehydration and your body is trying to compensate. And often the first sign of losing blood is a racing heartbeat. So of course you might have a racing heartbeat because you're anxious and nervous and this has just happened, but it's something, if it seems out of proportion, might be another reason to get seen. And of course, we're thinking about the whole vascular system. Could anything in the vascular system have been affected? So not every injury needs to go, but again, I would have a very low threshold. And these are some of the reasons that I would go to the ER for. And just so you know, as a provider, we're always very happy to see people. I know the balance is we don't want to overuse the medical system. It can also be quite costly, the ER copay, or if you get hospitalized or admitted for observation, it can be quite a large amount. And so it's always this balance. So we're just trying to focus on the things that if you call me, I would say, oh, this is concerning. I think you might need to stay. So what about shortness of breath? You're having some difficulty breathing. Your child is having some difficulty breathing. It's a little hard. So I would say basically anytime your child's having a hard time breathing, you probably want to get evaluated unless they have a history of this, a chronic history of asthma or a chronic history of anxiety that causes these symptoms. But obviously we're very worried about pneumothoraces. These are a lung, and I just had a child admitted this week with a pneumothorax. But if you look at this is an x-ray. This is the right lung. This is the left lung. You can see that the lung usually has all these markings in it, these little kind of hazy markings. And if you look here on this left lung, this is the lung, and this is all air. And a pneumothorax is where the air inside the tissue of the lung kind of escapes out and fills up the lung cavity or the air cavity, it's pleura, and that air compresses the lung. And this is totally treatable with sometimes just oxygen. Sometimes you need a chest tube, like put like a surgical tube in to drain it. It's treatable, but if you don't treat it, it can cause a lot of problems and can cause a cardiac or respiratory arrest if it gets too severe. So this is easy to diagnose. This is one of the few things with VEDS you can diagnose with a chest x-ray. This is a simple chest x-ray I'm showing you, and it's easy to treat. So I would say with shortness of breath, I would go, unless sometimes I will say, I see plenty of this, that it's anxiety. And of course, you can't assume that the first few times come, but if you know that that's a feature of someone's anxiety, just have to, oh, it got cut off. But if it becomes frequent, you have to learn yourself, okay, these are my anxiety symptoms. If I can make them go away pretty quickly, if I can do my exercise, if I can breathe through it and it goes away, I'm probably going to be okay. So what about pain? So pain is the really, really big deal that I think I get called most about in kids and that we most worry, and it can be anywhere. So right up front, pain is really common in kids, especially chest pain, belly pain, and leg pain. We see that every single day. I will say back pain is pretty uncommon, and so is neck pain. But every day there are kids with chest pain in clinic, belly pain, and leg pain, and these are people without VEDS. So how do you differentiate these are normal kid pains from this is something with VEDS? So for chest pain, what do we worry about? So the worrisome signs with chest pains are if it's prolonged, like if it won't go away, if it's severe, or it's worse with exercise. So I will say there's something called precordial catch that is super common in kids and teens and young adults, where your chest is fine, and then with no trigger, you get the worst pain. It hurts, it hurts, it hurts. It lasts for about 45 seconds and then goes away. And that is something called, most often something called precordial catch. It's totally benign. It's not a heart problem. And that happens all the time in kids. And so, but it's not prolonged. It is severe for like a few seconds, but it doesn't stay and it doesn't get worse with exercise. So that is more reassuring pain. It is reassuring if it lasts less than 1 to 2 minutes, if there's not a trigger, if it goes away by itself. Also, if it's reproducible with pressing. So there's a really common thing called costochondritis. And this is where after a viral infection, probably the sternal bone is getting inflamed from the virus, and it can, or you can get it from exercising a lot. And then this hurts when you breathe, or just hurts in general. But if you press it and it hurts, it's probably not cardiac. It's probably this costochondritis. So that's also really reassuring for chest pain. What about abdominal pain? So abdominal pain is extremely common in children. So how do we tell if we need to worry with VEDS? So one thing to say up front is I'm going to talk about kind of more severe abdominal pain. Constipation can certainly cause abdominal pain. It's usually not an emergency, but it definitely should be dealt with because in VEDS, it can become an emergency with impaction or GI bleeding or GI perforation. So that's just a sidebar that chronic constipation should be dealt with. That is a really common cause of abdominal pain. So when do we worry if someone calls with abdominal pain? So if this is a new pain, it's not a pain they've gotten. If it's accompanied by vomiting or bloody stools, if it's intolerable, you can't, this is like terrible pain, I can't eat, I can't do anything, of course, come in. If it's not going away, or if it's accompanied by other signs like a fast heart rate, sweatiness, something you're worried about, that's when would come in. Now, if it's very short, if it's better when you stool, if it's better with antacids, those are things that are reassuring. If you can do a home remedy and make it go away, we're not quite as worried. So, all right, I was just looking. Let me know too if there's any, Ryan, any no questions so far, right? I can't see the Q&A screen. I'm happy to answer anything if something has come up already.
Nothing yet.
Okay, great. All right, what about arm and leg pain in kids? So leg pain is really common. And the one time we worry about is if it is very focal or localized, like these two people have large hematomas, right? Or even if you can't see a hematoma, if you can put your finger on it and it hurts right there, that's kind of weird. That's not like the normal leg pain that's like growing pain in children, if you ever notice that it's associated with numbness or tingling in the limbs, that often suggests that a nerve is compressed, or weakness that affects the nerve, that suggests nerve damage. That's when we really worry. If the pain is very severe or if it's associated with any swelling or bruising, these are times we definitely want to worry. Now, we are reassured by extremity pain if it's very short-lived, or if there's no clear bruising or swelling, or if it's during a period of rapid growth. Like I just saw a young man today and he has daily leg pain, but he's also 9 years old and has grown like 3 inches in the last year. And that's really, really common. So it's more, if it's acute, if it's new, if it's focal, or there's other features along with it is when we sort of really worry. Right. And of course, dislocations can cause this. Those are going to be more obvious. Now, one note about dislocations is I think, I can't see the whole list of people who are on the call, but some people with VEDS have common dislocations, right? They're an expert. They're an expert at reducing their dislocations, and some people have never had one. I would say generally you should be seen for dislocation, but there are the subset of people who are an expert. They can replace it themselves pretty quickly in a few seconds. And there's no reason, if you're one of those people and you've been in that situation, that you're to sit with a dislocation waiting for a doctor to reduce it if you have done it many, many, many times. But for the most part, most dislocations should probably be seen unless it's really easily reducible, which means putting it back in the correct location. All right, what about neck and back pain in children? So I just went over a lot of features. So, chest pain is really common, abdominal pain, leg pain is really common. Neck and back pain are pretty rare in kids. Now, certainly they can be seen with exercise, sports, housework, but I would have a really low threshold to seek care, especially if they're acute at onset. Specifically because the risk, the first vascular event often in kids is a vertebral artery or carotid dissection if you're going to have a vascular event, and those are both vessels in the neck. And that I think it's probably better to get seen than not get seen, given the rarity of neck pain in kids and the importance of finding a dissection if there is one. Now, obviously, these aren't happening in like 3 and 4-year-olds, but I've definitely had 9 to 18-year-olds that have had neck dissections. So this is just an example. So this is just a diagram showing you. So a dissection, is bleeding into the wall, and it's basically moving the lumen where the vessel gets further up, and it can cause stroke-like symptoms, but it can also cause neck pain. And so we just have to be really careful here thinking about neck dissections with neck pain. So, and for back pain too, back pain's pretty rare unless you've had like an outright injury. So I would seek care as well for that. Now, what about headaches? Headaches are super common. I see them every single day in clinic. And they definitely need to work with your pediatrician long-term if you're having frequent headaches or migraines, because these can cause a major impediment in life, a major impediment in school. And there's lots of good treatments for headaches these days. The time if someone calls me and says, my child has a headache, should I get seen? Or if this is the worst headache of my life, or if you're having vision changes or neurologic changes. Now, certainly some severe migraines can cause vision changes and neurologic changes. But if this is the first time you've had these and you're not a normal migraine, your child isn't a normal migraine person that has migraines, I would get seen right away to make sure that there's not something going on like a bleed. Although I will say the vast majority of the time, headaches in kids are not having a major problem, but it warrants being seen. So what about neurologic features? So neurologic features in healthy kids are pretty rare. So a list of some things I would worry about to seek urgently for are new tics. Now, tics are not that uncommon in kids, but if you're seeing a new tic in your child, especially with VEDS, it could be a small microvascular injury. It could be a tear. It could be, we're seeing some of these in kids and we're not totally sure why. If you're seeing other symptoms like facial or extremity weakness, that can be associated with stroke signs, numbness or tingling, a facial droop, or of course, seizures. And I would say for any of these, seek care urgently. Now, some kids do have what's called febrile seizures. This is if you're under the age of 3 or 4 and you have a fever. It's really common for kids to get a seizure, but I would still get seen right away so that head imaging can be done to make sure. The vast majority of time in young kids, it's normal, but I would still get seen to make sure and be followed. And of course, bleeding. So bleeding is pretty common in VEDS. I most commonly see these as nosebleeds or menstrual bleeding or bleeding from like a scrape or an accident. We know that people with VEDS can have poor wound healing. We know that they can be prone to bleed. Some people are taking aspirin for history of vascular injury. And the time to really seek care is if the bleeding is not stopping, if this is new unexpected bleeding, or of course, if you're having other signs like dizziness, if you're nauseated, other signs going with it. Now, a lot of families deal with nosebleeds all the time, and you're good at dealing with it. And if you're able to stop it, awesome, fantastic. You don't need to get seen. Same with menstrual bleeding. Although I will say I've had more than one young woman come with menstrual bleeding in VEDS who were quite anemic and needed to be treated with either iron, rarely a blood transfusion, and ultimately medication to help their bleeding be less, which is possible. So to definitely get care for bleeding. Um, I wanted to talk briefly. I don't know if our other speaker is going to talk about carotid cavernous fistula. This is pretty rare in children, but it's kind of, we call it in medicine pathognomonic, like a clear sign is if the eyes get red right away. It's usually bilateral, I'm sorry, unilateral, one eye, blurry vision, and a bulging red eye. And this can be what we call a carotid cavernous fistula. And so this is a vision complaint. This is like absolutely go to the ER. And it's basically where the carotid artery, those are the neck arteries I mentioned, it goes up right behind the eye here. And sometimes this little wall can perforate because this is in someone with VEDS. It can bleed into this and cause a lot of pressure on the back of the eye and cause this redness. And so if you see this, now this is different than like conjunctivitis, like pink eye, where it's kind of red and kind of itchy and kind of oozy. This is like mostly pain and a bright red eye. And so often can be associated with ringing in the ears. And this does need to be treated. So that is definitely an urgent sign to get seen, this red eye, and could be a carotid cavernous fistula. Mostly happens in adults. It's pretty uncommon in children, but it can be seen in sort of later teenagers. I think those are all the symptoms I was going to talk about and features to come talk through. I'm happy. I don't know if our other speaker is here yet to take some questions while we're waiting or to answer if there's something I hadn't brought up about concerns that you guys have when you're considering going to taking your child to the emergency room.
We do have a couple of questions that came in, although they would apply to the adult population as well. So I think we're going to hold those for the end.
Okay.
But actually, yeah, let's take just a second. I had a couple of questions just as I think about parents whose children may be too young to appropriately share their symptoms with mom and dad. What types of things should mom and dad look for? Or perhaps we're talking about the teenager who maybe has a test tomorrow or a dance at the end of the week that they don't want to miss, and so maybe they're not speaking up when they should be. So if you can just kind of address some of these more difficult situations with regards to identifying when it may be time to take a child into the ED.
Sure. I will say first for like the toddler or the infant, complications of VEDS are exquisitely rare in that population. So you always have to weigh it with that. I have had one child have a major event, which was a bladder rupture. And it was clearly, he was screaming horribly. But I think some more subtle signs you might see is if they're not eating, if they're very fussy, not acting themselves. Those are kind of, if they're not absolutely crying out of pain. But sometimes like GI symptoms can be like a severe constipation. It can be just like a really fussiness or a whininess. And often the first manifestation for lots of young kids is lack of eating. They just don't want to eat. They just don't want to drink. They're very fussy. For teenagers, that is really hard. I mean, it's just getting to know your teen and their signs because there's a lot of other motivations. It might be not wanting to do a test, like you said, or might really wanting to be going to a dance. So I think any of these things I brought up could happen with teenagers, and it's keeping an open dialogue with them, keeping them educated, and having them know because there's so many different signs. You just need to have an open dialogue and have them be able to tell you like, hey, do we need to go to the ER? And a lot of times that's a test. Like if the teenager says, I think we need to go to the ER, that is usually like they're internally worried, or do we need to see the doc? I more often see kids that are like, if they're trying to get out of something, you say to go in the ER, like, no, 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 no. But I rarely see kids who feel really awful who don't want to go. Like they do often want to seek care. But it's much harder in teenagers. We really have to empower them to speak up and work with us.
Thank you so much. Yep. So, like I said, the other questions that have come in, I think I will save to the end and maybe have both you and Dr. Penna address those. So, at this point, Dr. Penna has joined us. Welcome, Dr. Penna.
Hey everybody, how you doing? Sorry, I'm coming from work, so just a few minutes late. Let me pull up my screen here. Let's see. Okay, everybody can see that screen?
Yep, looks great. Thank you.
Let me just bring this to the bottom here. All right. Hi everybody. Some of you may know me, some of you, many of you probably not. We haven't had the pleasure to meet yet. My name is Rob Penna. I'm currently a senior emergency medicine resident here at George Washington University Hospital down in DC. I am going to be joining several of our Marfan's and connective tissue disorder researchers that work with the Marfan's Foundation and VEDS over at UMichigan for the next 2 years doing anesthesia critical care as a fellowship. And my area of research in particular, having Marfan's myself, is in a lot of aortic pathology, but also talking to you guys and everybody with Marfan's, VEDS, Loeys-Dietz, and all these connective tissue disorders, just to kind of educate patients a little bit more on, what to expect when they come to the ED and today, like what to look for. Again, just a little background about me. So like I said, emergency medicine and critical care is my background. I included some pictures here just to kind of remind you guys that you have a lot of doctors that care a lot about you. Dr. Eagle is there on the top right, Dr. Shalhoub, who's a vascular surgeon out in Oregon on the top left under me, and then under my picture, and then Dr. Marion Bowman Hoffman on the bottom left, and Dr. Robert Old, who's a Canadian emergency medicine doctor who also works specifically in aortic dissection on the bottom right. So these are all the mentors I specifically work with, but you guys have a very robust community of doctors that really try to do a lot of good work that I'm hopefully trying to add to over time, just to really, make sure that in the emergency room and in the ICU, we're really taking the best care that we can of you guys. Like I said, I have Marfan's myself. I actually had my aortic root replaced when I was 23, and I had both of the lenses in my eyes replaced when I was 14. So I've been there. I have the unique perspective as both a physician and a patient. So I've had open heart surgery. I've had a bunch of stuff done. So thank God no dissection, but I've been through some procedures that were pretty cool. So I have a bit of a unique perspective on that. That's so another reason why I'm pretty invested in this. So, like Dr. Morris had already talked on and did a great job. She actually stole a lot of my thunder, but that's a good thing because there's a lot of overlap between adults and kids. There are some little nuances that I will bring up, but she brought up first and foremost, right, Ehlers-Danlos and all these connective tissue disorders, they are by definition systemic, right? So they affect most, if not every single system in the body. For Ehlers-Danlos, being a connective tissue disorder, that includes wherever connective tissue is. Blood is considered a connective tissue. Bone and muscle. We always worry about the vasculature is the big one that at least from the emergency perspective, that we care a lot about. But it is really important that you consider all these other things: bowel, uterus, and lung, and so forth. So over here on the left, I just included, this is what the VEDS website kind of included as the main things to look for. And after looking at some other, emergency medicine sources, the lists are pretty similar. So these are kind of the ones that I want you guys to focus on. So the key with VEDS that's a little different from Marfan's, and that I'm personally trying to make my colleagues in the ED more aware of, is that whereas Marfan's, we're very aware that aortic dissection is kind of the biggest thing that we worry about. VEDS it's really any vessel is fair territory. So we really need to make sure that we understand from an emergency perspective that, yes, the aorta being the largest blood vessel in the body is the one that has, a very significant chance of dissection or rupture. But the carotids in your neck, the femoral artery in your leg, the brachial artery in your arm, all of these are the celiac artery that feeds your gut. All of these are very important, and in vascular Ehlers-Danlos, any of them can be affected. Some obviously more commonly than others, but it's still something that I want you guys to be aware of, because the symptoms may be a little less typical that the patient or the physician might expect. Another big point I really wanted to mention was it's very important for you guys to know that VEDS does have an increased risk of intracranial aneurysms. So these are little sort of aneurysms that bulge off from the vessels that feed the brain. We'll get into that, and that's what kind of Dr. Morris had alluded to a little bit in terms of any neurologic symptoms. So worrying about stroke and potential intracranial or brain type of hemorrhage. So that can happen in VEDS. Pneumothorax is also key. Carotid cavernous sinus fistula, as she touched about on the end. Bowel perforation, which is something I would say some of my colleagues in the ED are not as familiar with. So that's something that you guys should really look out for and be an advocate for yourself when you're in the ED and bringing forward your symptoms to us. Uterine rupture for sure. We are aware that all connective tissue disorders and VEDS especially, pregnancy is a very tenuous time for the body in general. So obviously having VEDS, we just need to be a little more careful, and having a good obstetrician that really monitors your care and has a good familiarity with these diseases and can advocate for you and talk to your emergency medicine doctor at that time. Super important. And then musculoskeletal injuries, which are some of the more classic, the hyperflexible joints and the flexible skin and all of this kind of stuff. So we'll get into that. So when to go to the ED. So for arterial dissection or rupture, so to understand an artery, right, is essentially the high tension vessel in your body that feeds whatever is downstream of it, right? So that's your aorta, that's your carotids in your neck going all the way up to the circle of Willis and all the blood vessels in your brain, arteries going down your arms, arteries coming off into your abdomen, so your celiac and your superior and inferior mesenteric arteries, and then your femoral arteries that sort of go down and bifurcate into your legs. So these are kind of really the main and important arteries. Of course, there are many others. And they all have 3 layers. So they have 3 different tunicae, cloaks is the Latin word for it. And what can happen is we always say dissection. And what does dissection mean? It means essentially that at least 2 of these layers separate. So then what can happen is you can actually create a false lumen or a false track that blood can, and this is where the pain comes from that most people experience, although some people may not even experience pain when they have a dissection, which kind of makes it harder for me as an ED doc to really diagnose it. So, but the symptoms downstream might be apparent to you. So if you have a dissection in the aorta, people may come in with the classic, as Dr. Morris was saying, persistent pain is kind of key. It's typically, it'll be a classic chest radiating to back pain in the middle between the shoulder blades. It's tearing, it moves. That's kind of like, as we say, patients read the textbook, so they're coming in with the classic presentation of this. There are many dissections. So in the work that I do personally is dissection and rule out of aortic dissection in the emergency department. Up to 40% of dissections can be without pain. So the literature says really 90% usually are. So it kind of goes back and forth. We don't have a great number. Most will come in with this classical type of pain. But if you have any symptoms that make you feel uneasy, unusual, and you know about your body best, and you have a confirmed diagnosis of VEDS or a loved one does, it's definitely a better idea than not to come into the emergency department to get evaluated. So that's kind of the pain that we worry about. Some people can have, same with like a heart attack. You may have that, that sort of like pressure, central pain goes down the left arm. You guys are all aware of that. But some people with a heart attack only present with nausea and nothing else. They may feel like they have reflux or GERD. So again, same with dissection. They can present with all these kind of weird different symptoms, maybe pain that radiates up the neck a little bit. If you syncopize, or if you pass out, that is a huge, huge risk for a sign that tells us that you may have had a dissection. If your blood pressure, if you guys monitor your blood pressure at home, it's always great to have a cuff. If your blood pressure goes through the roof or it drops and it becomes unstable and, EMS gets there with the ambulance at the bedside and says your blood pressure is either way too low, way too high, that also lets me know that I have to worry about a vascular emergency. Loss of a pulse or pulse differences. You're not really going to feel this as much as I am in the ED, but your right arm and your left arm, or your right arm and your right leg, for example, might have 2 different pressures, right? And so I'll take a blood pressure cuff and see if they're different or not. So this is something to consider as well. But if you have any stroke-like symptoms, that you might pick up in that limb. So if all of a sudden you can't move, your fingers, a little bit of tingling, paresthesia, as we call it, is usually very nondescript. It can indicate something. But what I'm usually more concerned about is that if you cannot move your hand at all, it feels completely numb, it fell asleep, it's like a stroke. So that's what I kind of worry about. And again, because all these blood vessels feed the brain and everything downstream in your body, this is what we kind of worry about. And then arterial rupture is the more dangerous and the more emergent, is even more, it's more upfront, I should say, because whereas a dissection is kind of a sort of tearing of those arterial layers, and that can sort of move and tear further and further down the aorta or the blood vessel in question. A rupture is just a completely bursts open, and that can, unfortunately, in the case of aortic dissection, cause in the thoracic component, so like in the aorta up here, which feeds the heart and essentially the brain, 40% is immediate mortality. It's incredibly dangerous, and so that's why it is so key that I go for my echoes and I go for my MRAs for my aorta, and it's really important that you guys keep up with that, because having a very good understanding of your aortic diameter, its growth over time, whether you have calcifications, any wear and tear in the aorta, keeping your blood pressure under control, being on your proper medications, all of that reduces the risk for this, because it is incredibly dangerous. But for those patients that do make it to the ED with rupture, these are what I worry about is essentially if you have rapid swelling or a hematoma, which is essentially now the blood vessel is just sort of getting larger and spilling blood into areas or collecting somewhere. It may be in the neck. All of a sudden now you have a bulge in your neck that is pulsatile. If that's anywhere in your belly, if you have a pulsatile mass that's kind of like beating and it's large and it wasn't there a few minutes ago or it wasn't there a day ago, that's an emergency. You need to come straight to the emergency department because that will require surgery more likely than not. Shortness of breath, again, lightheadedness or passing out completely. And again, all the stroke symptoms as well. So loss of pulse in an arm or a leg, even if you have an arterial rupture in the brain from like those aneurysms I was telling you about that vascular Ehlers-Danlos patients are more susceptible to from these outpouching, these aneurysms that then burst, then you need to worry about classic stroke symptoms, facial droop, loss of vision in an eye, vertigo. Vertigo is key. Not dizziness, yes, lightheadedness, but vertigo is key for me because that tells me you may have a cerebellar stroke in the back of the brain, which measures balance. So vertigo would be like kind of like that swinging sensation that the room is spinning or the floor is kind of like shaking under your feet like a ship. Some of you guys may have experienced vertigo and you kind of know exactly what I'm talking about, but something to keep in mind for sure. And the key with any loved one, any type of stroke symptoms, please come to the emergency department as soon as possible. I have more often than not, I get these patients that come in, they sleep it off. They say, oh, I'll see if I feel better in the morning. And then they tell me my symptoms were 24 hours ago. And if it was from a clot, which can sometimes happen if your artery dissects and forms a clot, and then that clot maybe in the neck breaks off and goes to the brain, I have 4.5 hours as an emergency doctor to give you a thrombolytic or a something to break up the clot. I may not do that in the case of an active dissection, but I can get you to the OR in 24 hours to have them remove that clot if it is big enough, because after 24 hours, neurology and interventional radiology will probably not touch that. So it's just get to the ED as quickly as you can, please. So this kind of talks about, this is just a breakdown what we use as emergency doctors, vascular surgeons, cardiothoracic surgeons, everybody that when they talk about the aorta in particular, because again, that's the biggest artery in your body, that's where all the money is, but it's any artery that comes off the aorta. So, we typically use the Stanford classification. So Stanford just, all that tells me is the arch involved. So you can see here, if you see my cursor, the type 2, type 1 or type 2 DeBakey is a type A dissection. That means, is this ascending part involved? So here from the heart going out here into the chest right here, right before all the vessels into your neck sort of shoot off. That requires emergent surgical repair. Everything downstream in this type B, which is in the descending part in the chest, and everything in the abdomen below it, that can affect, you see these two little branches here, those are your kidneys. Your kidneys could get affected by that as well. Sometimes that's medically managed. Sometimes now they're being more aggressive and putting in stents. But either way, these are all emergencies. And then you need to come to the emergency department for that. So again, look for all those symptoms: neurologic, pulse differences, passing out, blood pressure differences on your cuff, pain in your back, your chest, your abdomen, anywhere, especially if it's that tearing, migrating, and really more than anything, persistent pain. It does not go away. This type of pain usually doesn't, and it's also what we call a thunderclap pain, meaning it just kind of comes on out of nowhere and then it just does not go away. It doesn't, sometimes it can build up if you had an aneurysm, a little dilation beforehand, but usually it's what we call thunderclap, meaning it just completely comes out of nowhere and just hits you hard. So that's the classic presentation, but remember, you know your body best, and not every patient reads the textbook. Everybody is different, okay? So in terms of lung, Dr. Morse had already mentioned, same with kids as adults, pneumothorax is key. So this is kind of, I see pneumothoraces in the ED all the time. They're not always, again, something you need to come to the ED for, something that can very easily be managed for the majority of cases. You'll have essentially some air that will, oh, sorry, I'll go back there for a sec. Essentially what will happen is, because again, the connective tissue in the lung that connects the pleura, that connects the lining of the lung with the chest wall, splits. So what will happen is air will get in that space in between, and I'll show you a picture of an X-ray afterwards. And like Dr. Morris said, sometimes I will just literally put a non-rebreather mask on your face and just have you breathe in 100% oxygen, and that will allow it to heal over time, depending on the size and how stable you are from a breathing standpoint. If it is too big, then I may elect to actually put a chest tube in you, or the surgeon will put a chest tube in you. Sometimes we use pigtails, which are a little bit smaller, and it's a catheter that kind of curves like a pigtail. If that's the case, discuss with your surgeon what you want. So they have their preferences, bigger or smaller chest tube, depending on the size of the pneumothorax and how big it may be, how quickly it may be expanding. They're not the most comfortable procedures. They do hurt. So, always asking for numbing medication like lidocaine or bupivacaine beforehand. Asking for the placement to maybe be a little more in the front. because that way most people don't think about this, but I had a surgeon who taught me because she actually had a chest tube when she was younger. Having your arm just rub against the, that darn chest tube, while you're in the hospital for 3, 4, 5 days, it's really annoying and it actually does hurt. So maybe discussing the placement of the tube if they're not in a rush and they can take their time and talk to you about the procedure. If it is more emergent and I'm in the emergency room and I'm throwing a chest tube in you, that could be because the air is expanded so much. It's actually pushing your heart off to one side and it's constricting the blood vessels that return blood to your heart. So your blood pressure is actually dropping, and that is a life-threatening emergency. So that can happen. But again, fortunately, the majority of pneumothoraces are not what we call a tension pneumothorax, which is that you're creating tension in the chest and that constricts your blood vessels. But that can happen. And again, you need to come to the emergency department. So look again for thunderclap, acute onset chest pain, shortness of breath, dizziness, passing out, and you're just like, you can't catch your breath. All right. And especially if you've had a pneumothorax before and you know what it feels like, pneumothoraces tend to recur. So if you've had one and you feel like you're having another one, just please come to the ED and get a chest x-ray. It's very simple, it's cheap, it's fast, and I can even throw an ultrasound on your chest, a probe, and see if there's any free air there. In terms of ocular emergencies, Dr. Morris had mentioned this again, more in adults with this carotid cavernous sinus fistula formation. So that's just a fancy term that means, again, a fistula is an inappropriate connection between two places. So you can have, you can have what's called enterocutaneous fistulas. So if any of you guys have ever had belly surgery before and you have a little tunnel that merges the bowel with the surface of your stomach, and your surgeon has told you, this is a fistula, that's a connection. This connection in particular is from the carotid artery, which goes into your neck. And like Dr. Morris was saying, behind the eyes, you have a lot of, there's a lot of important stuff back there. So you have your ocular nerves, you have a lot of your cranial nerves as well, which come right off the brain and sort of feed into the face with sensation, vision. And what can happen is that if the carotid artery bursts or it makes a bad connection with this cavernous sinus, then you can get compression of all of these vessels to the point where it might even cause permanent ischemia and damage, which can mean loss of vision, among other things. So, and like she said, 100% correct. This is not a subtle thing. This is, I'll show you a picture of it, but this again is like thunderclap, abrupt. Your eye is not going to be like a little itchy and irritated, like she was saying. This is like your eye is bulging out of your face. It's what we call chemosis, meaning your eye is literally bulging and swollen, and you can't move it. It's fixed, and it is usually unilateral. Sometimes if it's bad enough, because again, VEDS can lead to bleeding disorders, bleeding diathesis, you can have involvement of both eyes because blood will just fill that entire cavern on both sides. But again, the eye is basically fixed. It's proptotic, meaning it's popping out, and you can't really move it from side to side, and you've lost vision in that eye. It is very dramatic. And again, just come straight to the ED because we can help you take care of that, and hopefully we can save your vision as well. But again, all these things are time sensitive, right? So that's the key. So pneumothorax here you can see, right, is again just air, just sort of compressing and squishing this along a little bit. If it's just a little sliver, right, the dark purple, just a little tiny bit, then I can just put oxygen on you, we're done. Here it's a little bit bigger. You can see on the chest x-ray, see how like the lung kind of crinkles up over here. That's the lung, and see how here it's nice and aerated, the lung is full. Here's the pneumothorax. Now just imagine if this expanded rapidly, your heart here, your aorta, and all your blood vessels shift to the opposite side. So imagine the heart being pushed against that opposite wall. That is a surgical emergency. I'm in the trauma bay with you, trying to coach you and tell you, listen, I have to throw a chest tube in you and I have to get this air out now. So that's what they would do. And then the cavernous fistula right here, you can see it's very dramatic, right? You're not going to miss it. So the fortunate part of this dramatic diagnosis is that it is dramatic. You will not miss it. So again, if your eye looks anything like this, please just come to the emergency department immediately, and that way we can decompress it and then hopefully get you into surgery if that is required. Sometimes they'll IR, interventional radiology will go up and essentially embolize this carotid artery or a branch of it. And then that will hopefully stop the bleeding. But that needs to be done way sooner rather than later, because the longer that those nerves that feed the eye and the rest of the face are compressed, the more the risk that nerve will actually die. And then at that point, it can't be saved. So just getting there sooner rather than later. Bowel perforation is I think, and again, emergency medicine docs, we all went to medical school, no matter whether you have a cardiologist, an OB-GYN doc, an emergency medicine doc, we all have our sort of what we call illness scripts. We have our diagnoses that we learned in medical school that are in our head. We have our buzzwords, and we know what to look for and what to think about. So when I hear tall, lanky guy coming in, 6'3", giant wingspan, marfanoid appearance, sudden onset chest pain, I'm thinking aortic dissection. Easy, done. Vascular Ehlers-Danlos is also decently well known, I would say, in the emergency medicine community. Loeys Dietz, you can ask any of my colleagues because the diagnosis only came out, what, 15 years ago? Very few emergency medicine docs are aware of this. So I just want to impress upon you guys, and I'll get to this when I talk about like the magic words to say in the ED. You really need to advocate for yourself and say that vascular Ehlers-Danlos is a connective tissue disorder. Think similar to Marfan's in many respects. It is different, and then that'll prompt us to look up stuff and make sure that we're on board. And we'll check your charts and everything, but just really advocate for yourself because for bowel perforation, that's not really something that happens in Marfan's nearly as much as VEDS. So that's something really specific, and I don't think a lot of my colleagues are really familiar with that. So when it comes to abdominal presentation, I would, and uterine as well. So like pregnancy and uterine rupture, I would really, really advocate for yourself and say, vascular Ehlers-Danlos, I know my doctor told me can lead to this. Can you please evaluate me for this? So bowel perforation really fast, as Dr. Morse was saying, again, it can sometimes be acute onset. Sometimes it can be indolent, especially in adults. Kids are a little smaller, a lot less space. If they had some bowel surgery in the past as well, it kind of like leads me into that direction. And the older you get, maybe you've had your maybe you've had an appendectomy, you've had your appendix removed, you've had your gallbladder removed. Make sure you know your abdominal surgical history. So when someone asks you, have you had any medical problems? I hate when patients say to me, no, I've never had any surgeries. Oh, well, I saw on your CT scan that you don't have a gallbladder. Oh yeah, I had my gallbladder taken out, 2 hernia repairs and all that stuff. So make sure you even that minor stuff, really important because all those surgeries form strictures, okay? And which are essentially scar tissue. Every time a surgeon goes in somewhere, there's going to be scar tissue. So in the bowel, that can cause the bowel to sometimes torse and twist on itself. And it can also cause the bowel wall to weaken and sometimes burst open, which in the case of perforation, the bowel is filled with stool and air. Okay. If that stool gets into the rest of your belly, that's all bacteria that's just going to seed and cause sepsis. And that's an emergency. And if air gets into the free wall of the abdomen, essentially what can happen is, again, this can happen quickly or this can happen over days. And it's, maybe if you're 75, you don't really notice it as quickly. But your abdomen will start to become tense. So when I press on your belly, it'll be a bit rigid. You'll have what we call guarding, which means that if I go touch you, you'll kind of like, you'll guard yourself because you'll be in that much pain. You may have rebound tenderness, which means that if I push and then release, the pain is actually worse when I release. That's a little harder to find. That's more of a nuanced exam that a physician should do, not you. But again, if you notice that your abdomen is swelling up, if you're no longer having bowel movements, I go to the bathroom twice a day, normally, regularly, not a problem. It's been 5 days. I haven't had a bowel movement and I'm not passing gas. That is key. If I'm vomiting after every time that I eat or drink something, so postprandial emesis, right? So I can't tolerate anything by my mouth because my abdomen is now perforated and nothing can find its way down. Everything comes back up on me. So you need to get to the emergency department right away. For uterine rupture, again, if you're pregnant, pregnancy again is a very risk-laden state for any healthy woman. And so someone with vascular Ehlers-Danlos, again, worrying about, concomitant dissection, worrying about, in this case, uterine rupture. So we are familiar with that in the emergency department. At that point, we're calling our obstetrician immediately to come see you guys. But saying, listen, I think I had this sudden onset, persistent tearing pain in my pelvis, in my abdomen. I have bleeding. My abdomen is distending. Sometimes what you can even happen as well, this would be something I would feel more in exam, but you can even feel a presenting fetal part. So what'll happen is that a hand from the baby may actually make its way through the cut. That is a bit more dramatic, and you'll sort of feel that from the skin on your abdomen. But the point is that if you all of a sudden are experiencing this massive abdominal pelvic distension, pain, and those types of symptoms, please come to the emergency department. We can do an ultrasound very quickly at the bedside to assess you and get OB-GYN in there and see if we need to get you into surgery. Okay. And even if you didn't, we're glad you're here because then we ruled it out, right? Which is equally as important. All right. So here are quick pictures of that. So you can see these loops of bowel here. So this is the colon kind of runs like this, and it's like you're cutting it this way. So you can see all of this bowel was completely distended and filled with gas. And you can see some free air actually right there at the top. And this person's abdomen, you can see, is very round, right? So they're kind of bulging like this. And you can see some free spotted air right here, those little black dots, because air is black on a CT scan. Here's uterine rupture here, all right? A big thing for uterine rupture too. If you had a prior C-section or a myomectomy where they went in for fibroids to cut them out, huge problem as well. So again, that can all lead to any time that the uterus has been violated at any time surgically. And again, with VEDS just on top of that, you really need to worry about uterine rupture. And this is abdominal distension from a belly perf. And here's uterine rupture here. So you can see the exam is pretty impressive. Sometimes again, it may be slower because it's just a little bit of gas. in a tiny little part that leaks out. Sometimes it's a very large pocket that just immediately releases, and now you've just got this very distended, swollen, tender abdomen. MSK is super fast. Dr. Morris went over this beautifully, so I'm not gonna insult her wonderful presentation by adding any more to it. It's the same in adults as it is kids. The only difference is that the nice thing about adults is my patient's bones are fully developed. So that way I don't have to worry about reading these really complex x-rays when they're 5 versus when they're 50. So again, some of you guys may have dislocated your shoulder on a regular basis. I have a guy that's a frequent flyer. He's dislocated his shoulder 50 times and he just pops it right back in and he comes in just to make sure that it's in place. So we can do that, get an x-ray. What I worry about is, like Dr. Morris said, neurovascular compromise. So every single bone has arteries, nerves, and veins that run along with it, with the muscle that is attached to that bone. So if you have a joint dislocation and now you have downstream or in that area numbness, weakness, or you notice, worst of all, something called compartment syndrome. And this comes more with fractures than dislocations, but if the compartment, so like let's say you have a forearm fracture, and now your forearm is getting very distended and it's tense, it's hard, and now you're noticing tingling in your hands because of that. Maybe you feel a radial pulse and it's a little bit weaker than it is on the other side. That is a surgical emergency where you need to actually go in and have a fasciotomy where they open up that fascia. Because what you've done, especially with VEDS patients that will tend to bleed, and you're having recurrent fractures, you're creating a lot of pressure where all of that muscle is with the arteries, the nerves, and the veins. And again, just like the cavernous fistula I told you about, anytime you have a lot of pressure, you're compressing nerves and arteries and veins. When that becomes prolonged and permanent, you do permanent damage. So again, just keep an eye out for that. Fortunately, most fractures are not this, but there are certain key fractures to look for, kind of like what we call supracondylar. So here in the humerus and the arm, right above the elbow, that can cause downward effects in the hand. So keep an eye out on that for neurovascular compromise. Also, what we call a tibial plateau fracture. So right if you can feel the bump on your knee, right under your kneecap, you have like a what we call the tibial prominence. Around that area, if you have a fracture there, that can actually cause a lot of problems downstream in the leg as well. So just keep an eye out for that. And again, if you have a suspicion for a fracture, get an x-ray. Come in and get an x-ray. We'll take care of you. So really fast, because I know I'm getting a little over time here. So magic words, right? So in the emergency department, this is a fast-paced environment. You're going to be in a waiting room with 60 other people, triage nurses up front. You've got 5 other families screaming because they haven't been seen in 4 hours. And you're coming in and they took your vitals and now you're just sitting there waiting and nothing's happened to you. If it is emergent, obviously, you're going to be rushed to the back immediately because the triage nurse is going to look at you. First of all, if you came in by ambulance, you're coming straight to the back and I have to evaluate you before I even send you to the waiting room or send you to a proper room. So that's one thing. If you're coming in because of a fracture and you're worried, well, maybe I've got some tingling in my hand and I'm not really sure, you'll come in by your car, by private vehicle. The nurse will triage you. And then basically we'll give you a score in the waiting room and we will see you in the level of the order of acuity that you have. So if you're, it's called an ESI score. So if you were an index of 1, that's somebody who's like an active cardiac arrest. That is not you. Usually like a fracture would be something like a 3 or a 4. A 5 is someone who's like, I stubbed my toe. I've been sitting here for 12 hours. I can sit here another 12 hours. That's fine. So we will grade you and then get you back as soon as possible and as is appropriate. But again, saying magic words like I have a connective tissue disorder. I've had a fracture in this arm before and it actually had compartment syndrome. It actually had vascular damage. That's what sort of tells us we need to get you back sooner rather than later. So again, I kind of already went over a lot of these words, but for aortic and arterial dissection, thunderclap pain, persistent, tearing, migrating, location, chest, between the shoulder blades, up the neck, down the arm and the leg. These are all things to worry about. Shortness of breath, syncope and passing out, right? These are all things to worry about. Numbness and weakness, stroke-like symptoms. These are all the things that tell me as a doctor, I can't have you sitting out there. I need to take care of you now. Pneumothorax, shortness of breath. I've had a pneumothorax before. I've had a chest tube before. Maybe I have some broken ribs that can also lead to a pneumothorax. Carotid cavernous sinus thrombo. Again, I will probably see that on exam, but I was doing fine. I lost vision in my eye an hour ago and I can't see. My eye is fixed. It's bulging. There's pressure. It's red. And this was not there an hour ago. Bowel perforation. I have not had a bowel movement in 5 days, 6 days. I can't keep anything down my mouth. I throw everything up that I've eaten. I'm not passing gas. My abdomen is completely distended. I've had belly surgery before. Uterine rupture, I'm pregnant, I have vascular ehlers-Danlos. I follow with an obstetrician specifically for this reason, in addition to obviously normal prenatal care. And I had just had this acute onset pelvic pain. And the musculoskeletal injuries, neurovascular compromise. So those are the big things. So just to finish up really fast, again, what I want to teach you guys more so, especially in the adult world, I also cover a children's national from the peds side as well. So, I've kind of seen this too. Boarding and waiting times in the emergency departments are not getting better. They are getting worse. Unfortunately, it is a crisis of a shortage of nurses, a shortage of doctors. Our health system is just completely inundated, and we just don't have the infrastructure, and it's very much dependent on where you go. Some hospitals will be worse than others. So I want you guys to really just use these magic words and advocate for yourself. If you feel that you're somebody that, you have vascular Ehlers-Danlos and you have one of these potential complications, tell the nurse, tell the triage nurse, and say, listen, can you tell the doctor in the back, because I'm just really concerned. I've been sitting here for 2 hours and my belly pain is getting absolutely worse. And I think I need to be evaluated. I need it to be upgraded in terms of me being in the queue and being seen. And they'd be more than happy to talk to the doctor, right? So, we're here for you guys. Again, you have a little patience with us, just because, again, if you're having an active aortic dissection, you're in the back with me. This is not the problem. But, if you're in the waiting room and you're having a broken bone and you're worried about some arterial damage or something, and it's taking a little longer than expected and your symptoms are getting so slightly worse, have a little patience with us. We are taking care of you. We are aware of you in the back, but again, advocate for yourself so we can get you back as soon as possible. Okay. Like I said, when you get to the ED, you will be triaged by the triage nurse. Make sure, again, your full medical history. I have vascular Ehlers-Danlos. What is that? Say that is a connective tissue disorder, and it is in the similar family as Marfan's. And this is what I am worried about. This is what I follow with a cardiologist and an orthopedic surgeon and an obstetrician and my general surgeon for, right? And these are things to worry about. And again, just because you have vascular Ehlers-Danlos, like Dr. Morris was saying, doesn't mean you're not immune to other regular problems. You can have a normal, regular bone fracture with no other problems, and it has nothing to do with your VEDS, right? VEDS just means you have a higher likelihood of having these certain more niche diagnoses. But when you come to the ED, you come to the ED. And again, when you say VEDS, me as the doctor, I'm going to maybe go down that track and think maybe your complaint is related to your VEDS. I should be thinking that way, but sometimes it might be totally unrelated. I have belly pain. Maybe this whole time you had reflux, right? But I need to be worried about, did you have a bowel perf? Are you having a dissection? Are you having some other issue that's related to your VEDS, right? But again, you're entitled to have any other medical problem like anybody else, okay? Right. And again, my job is I'm trying to educate people more so on VEDS and OISDs in particular, because again, VEDS we know about, I'm sure all you guys have gone to the ED at some point and they say, oh, you have Ehlers-Danlos. Can you do the thing with your elbow, like the hyperflexibility? I guarantee many of you have had that done before. But really reminding them that, yeah, the bowel is a huge part of that. The uterus is a huge part of that. Sometimes we don't, because we don't see these diagnoses often enough. That sometimes we miss the nuances. So that is your job to help us help you, right? And again, it's our job to take care of you, but always advocate for yourself. Never be afraid to speak up for yourself. Okay. Right. Give all your information as well. Okay. And the other thing is too, if you have any information available, like you have the names and the numbers of all your primary care docs and your cardiologists and your specialists, please give that to us. Please always, especially again, Marfan's, VEDS, all these diagnoses are ones where you want to, some people like, my mom wanted me to get a tag on my neck when I was young, so people, God forbid, would know if I were unconscious that I had Marfan's. It's something to consider. It helps us. More importantly, having a card. Everyone comes in, these 80-year-old people come in and they say, oh, I have my blood pressure medication. It's all written out on a list. You have no idea how helpful that is. Some people come in literally with a type sheet that's because they've had 50 different surgeries and even they can't remember, and says, in 2021, I had a bowel resection. And then 2022, I had another colon surgery, but then that one had a fistula and I had to stay in the ICU. And this one, I had a pneumothorax. And, so if you have a very complicated course due to VEDS and anything else, bring in a list, and it helps us. It really does. It helps us triage you faster, and it helps us think about what you may or may not have. So the more information we have, the better. And same with scans. If you had a recent scan of your aorta yesterday, again, that does not mean that you're scot-free for today, but it helps me a lot more, and as opposed to if the last echo of your heart and aorta was 15 years ago. All right, it does actually help me a lot. Okay, same with MRIs and X-rays and echoes and EKGs and any of those tests. Okay, and again, kind of a morbid thing to talk about, but in general, everybody should have this. And I always say this to every patient I talk to, doesn't matter how old you are or what problems you have, please have a medical healthcare proxy in mind. And not just in mind, if you're somebody who's now 50, 60, 70 years old, and I tell this to all my patients, VEDS or not, you need to have somebody who's going to be designated as your as your legal medical proxy and power of attorney. And that requires, depending on what state you live in, you need to have some forms filled out. Some people also have separately a living will or goals of care form, which you should also have filled out. So if you're someone, you've already had a surgery on your aorta twice, and you're 75 and you said, listen, I lost function in my leg, and if I, God forbid, have another aortic dissection and I'm unconscious and I don't want to be actively resuscitated in cardiac arrest, you need to write that down in a legal form, and you need to empower your loved ones to give us that information, because I, as the doctor, when you come into me unresponsive and unconscious and you cannot talk for yourself and your family member is 7 hours away by car and I can't get in touch with them, I'm going to resuscitate and do everything I can, because I have to err on the side of caution and try and bring you back and do what I can. It really helps if you have all that legally laid out. And again, even if you have a form that says, I don't want active cardiac arrest or what we say are sort of heroic interventions, we will still talk to the family before that. Obviously, we won't just say, oh, well, the paper says don't do this, so we're not going to do anything. No, of course, we will talk to your loved ones, but giving us that information, having it in your wallet, just this is my power of attorney. That way we can call them quickly and say, hey, what are the goals of care for your loved one? How soon will you be here? Because this is what I can do for you as a doctor, and what would you want, right? So that's essentially, and that also includes DNR, DNI, like I said. So do not resuscitate, do not intubate. And again, that is for any patient. I don't care whether you have VEDS or not. Just everybody should have this written down in the proper legal forms, depending on what state you're from. Right. And then finally, you know your body best, right? I'm a doctor. My job is to tell you this is medically what could be the possibility, right? You don't tell your plumber how to put in your plumbing, but you know your house, right? And you tell the plumber what's wrong, what you think is wrong, and what you want done. My job is to bring my expertise to help you and tell you what my limitations are and how I can help you and what the chances are of X, Y, and Z are. But you know your body best, and you need to, and doctors work with you. We do not use a paternalistic model anymore. This is shared decision making, and that's especially in the ED. We pride ourselves on that, right? Because I don't get to meet you often. I'm not your primary care doctor. I haven't known you for 30 years. So it's my job to really work with you to figure out what's going on. Okay. And again, please keep in mind, emergency docs, we love you guys. We're taking care of you. We are the highest burnout field of any specialty in the country. The reason why is because the cognitive overload, the number of patients that we're seeing, we are trying our best. I promise you, if it is life-threatening and acute enough, we are on top of it. I promise you. And if in that rare case where it's not, I'm having some blurry vision in my eye, I think I'm having a stroke, but the triage nurse says that, I can wait. I really need that CT scan now. That is something, open your mouth, say something, and we may miss something, right? We're not perfect. So please just be patient with us. And we're going to work with you. Okay. And that's it. Sorry, I went a little over, but hopefully that was helpful.
Thank you so much, Dr. Pennant. Yeah, we're getting a lot of comments in the chat. Thanking you for the information that you have shared. We are running a bit short on time, and there are some very specific questions in the chat that this may not be the best setting for. So just as a reminder, if you have a question that you posed that was not addressed during the course of the webinar, please do reach out to us at marfan.org/ask, which is our help and resource center. It can also be found at thevedsmovement.org/ask. And so if your question is not addressed tonight, we will be sure to respond to you there. In chatting with the community, honestly, a lot of the questions and concerns that I hear with regards to when to go to the emergency department are, number one, a lot of people complain about really just a high pain tolerance. So they really have just a hard time determining when a pain is significant enough to visit the emergency department. But then also, I hear concerns about not wanting to overburden the system with too many visits. And so they're thinking of others as opposed to themselves, which is, very unselfish. But, I think when it comes to emergency situations, let's be selfish and let's get ourselves to the doctor. But that is a concern that is raised. But then also, the thought of I can't go every time I have a pain that's concerning me because, the anxiety and the time and the medical bills and everything associated with that. So I think there's just a lack of confidence. And the problem is there's a lot of moving parts for everybody. That risk threshold and that degree of pain tolerance differs. So I don't know if you can shed a little bit of light on some of those concerns or barriers that people face as they decide whether or not to go in.
I can comment on the pediatric perspective. I mean, I think so much is just comparing to your baseline, right? like the biggest disc is how different is this than my baseline when you're trying to weigh whether to go in? Because certainly you can't go in every single time and you'll go crazy. You might get excess imaging, but it's always the first thing I said is like, is this normal for you? Right? Like someone just had a comment about auras and migraines, and certainly a migraine with aura can look exactly the same as a stroke initially. And so if you get migraines all the time and this feels like your normal migraine, and if I go in the dark and cool down the AC and take some, meds, I'm going to feel better in half an hour, and you do, great. If you've never had these symptoms before, you might be having an acute stroke. So much, I think the best measure is relating it to your baseline, and also knowing it's okay if everything's normal. We're not going to be mad. We're not, like we'd rather you get care and have a normal exam than not seek care.
100%. I mean, again, there really should be no guilt in this whatsoever, guys. I mean, if anyone's entitled to come to the emergency room on a frequent basis, it's going to be it's going to be men and women who have an underlying disorder that affects every system in their body. So, trust me, that there's no ill will whatsoever. In fact, we are happy when you come in, and more often than not, and honestly, the more often. Obviously, we don't want to see you guys in the ED from a good perspective. Like, we don't want you to have an emergency. But when you do come in, it does remind us and educate us about this as well. So even if you came in and again, you had a migraine and you didn't have a stroke and you're 30 something years old, and yes, you have vascular Ehlers-Danlos, I am going to scan your head because you're 30. I wouldn't normally scan a young woman's head at that age. But by you telling me that you had VEDS, and telling me my symptoms are a little bit off and a little different than that, that's all you have to say to me. And then I will say to you, are you okay with me then? I'm concerned. Are you concerned? Do you want to get the CT? It is radiation. We can try the migraine. There's a cocktail of meds we give for migraines. We can do that in the meantime. But to not lose time, do you want to do the CT scan? Again, it's all a shared decision-making model, and again, I'll tell you, once you say those magic words for me, it's it kind of opens up a whole new list of things that I need to worry about and things I can offer for you, right? So, there's no ill will whatsoever. I would rather you guys come in, seriously. Please don't feel that way ever.
Thank you so much. We've all seen it happen. We've all heard about it happening, but oftentimes when the words Ehlers-Danlos come up in the emergency setting, because of the hypermobility spectrum of disorders, it's not unusual for a patient to sort of see the trajectory of their path turn all of a sudden, and they're asked to show the physician how bendy their elbows are, and then perhaps they might be sent home without getting the proper evaluation or imaging that they need. A couple of comments in the chat with regards to being sent home with the bowel perforation. And so if somebody is sitting there and sharing everything they know about their condition and sharing their symptoms, and they see the trajectory of their path leading to going home versus getting what they potentially need, any suggestions or words of advice to help them to get that visit back on track?
What I will say personally, and that's why I love these webinars and hopefully I would love to come back and do a couple more with you guys for sure. When a patient comes to me and they know the medical terminology, that immediately convinces me that you know what's going on, right? When someone says, I have this disease and it has a thing and I'm not really sure, but when you say I have vascular Ehlers-Danlos, not just red, but I have VEDS, and I am worried about my, and you may not even remember the word perforation. You say, I'm worried that, I may have air in my abdomen. That just immediately tells me, oh, well, that means you've spoken to your doctor about this and that you're aware of what's going on. And I need to address that. I can't just brush that off. So that forces me to realign that trajectory and come back to you and work with you and work with your concerns. Because if you're saying, well, I have this weird connective tissue disorder and I'm having some belly pain, but I'm not really sure, that will make me work a little harder to get to maybe a bowel perforation. And that will increase the risk of me sending you home without maybe doing an abdominal x-ray at least. But if you say, I am worried because based on my symptoms and my doctor told me specifically, if I have the X, Y, and Z, I'm worried about a bowel perforation, I really want you to do an x-ray of my abdomen or a CT scan. That will 100% bring it back home for me.
Yeah. And I echo what was said in the chat. I think saying the word Marfan and what Dr. Penna said, if you say, this is not the bendy one, this is the one that's like Marfan, just saying that will often turn people around and be like, oh, because everybody's scared of Marfan syndrome and everybody knows what it is. And I hope, like you said, more people are learning about VEDS. I don't know. I talk to enough people, and that's the first thing I say when I mean, all my patients have my number, and it happens every couple of weeks that I'm talking to an ER doctor. And that's the very first thing I say is, just so you know, this is one that's closer to Marfan, except maybe worse. They just rupture. Or if it's belly pain, I'll say they can rupture their bowel. It's not the same. And I think if you say that right away, then they turn around. And then if you have something to support it, like the passport or something you're carrying, I think that can help.
Right.
I will also mention that I am in the process of revamping our emergency preparedness section of our website. There's a lot of good information, and I'm looking to pull it together so it's a little bit more accessible. But we've got some very concise documents that you can keep in hand and hand to the EMT or the paramedic, hand to the emergency room doctor that has very specific information about VEDS. And I will tell you what, those that, again, like Dr. Penna mentioned, those that have a diagnosis, other people don't come to you with that information in hand. Other people don't mention that they have, a mutation in collagen 3A1. That's just not language that people use. And so it is the specifics. It is knowing your condition well and being able to advocate for yourself, and knowing your condition well and being well practiced at telling your story and sharing clearly your symptoms is really the key. There was a little conversation that occurred in the chat that I want to bring up real quick. Dr. Morris, I think that you had replied just to the panelists, and I'm not sure if everyone saw
Oh, sorry.
your answer. That's okay. So I'm going to read it here, but
Yeah.
a parent in the chat brought up that the blood in the stool is very common for kiddos with VEDS, just following even just a bout of constipation, and it's just due to small tears. And so Dr. Morris replied that a small amount of blood in the stool is very common in children with VEDS. It's usually not an emergency situation unless it is new or large in volume. So I did want to just make sure that everybody was aware of that comment and then the response. I am not seeing any additional questions coming in. And again, I kind of wanted to keep the questions and the answers a little bit more broad. I do know there's some very specific questions that came in tonight. So again, I would just encourage you, if you have a question that was not addressed tonight, please do visit marfan.org/ask or thevedsmovement.org/ask. This webinar was recorded and it will be on our YouTube channel shortly, as well as that revamped emergency preparedness page. It will be front and center. I think this was a great chat tonight, and I appreciate the experts that hopped on with us and shared their expertise with us tonight. But again, please do reach out via the Help and Resource Center if you have any additional questions. And once again, thank you all for joining us. Thank you, Dr. Penna and Dr. Morris, for your time tonight. We greatly appreciate it. And I know a lot of comments in the chat saying that some things just resonated, and some words of advice that the two of you shared with us tonight really were extremely helpful. So thanks again. Thank you all. And we'll see you next time.
Thanks everyone for coming, and thanks Ryan for hosting.
Thank you guys so much.
Thank you.